Thank you for joining us at the 5th Annual Global Summit on Kidney Disease Innovations, If Not Us, Who, and If Not Now, When, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Diana Clynes, and I'm the Executive Director of AAKP. I'm proud to have been with AAKP since 2005. In 2018, I was selected by our patient board of directors to serve as executive director of the association, and I'm honored to implement and execute the mission and national strategy of AAKP since then in very close coordination with past presidents Paul Conway, Richard Knight, and our current president, Ed Hickey. In 2019, AAKP announced two major initiatives, AAKP Global and the Decade of the Kidney. AAKP has engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the necessity to save more lives. We believe that a united patient voice can drive more intelligent alignment of the policy, regulatory, and payment decisions necessary to bring new, safe innovations to patients with undue waiting and needless interference. Across the globe, AAKP is with patients, medical professionals, researchers, and medical industry allies to address the many unmet needs of the global kidney community. AAKP believes that the international collaboration can help close the gaps in U.S. and in countries where healthcare systems and/or infrastructure do not fully support patient consumer choice or immediate access to new treatments. It is my pleasure to moderate our session titled Global Patient Empowerment, New Patient-Centric Tools and Resources to Inform Patient Care, Choice, and Shared Decision-Making. This is a very strategic session of the Global Summit because it provides patients across the globe and here in the United States with updates on practical and high-impact advocacy tools that are under development or recently created. AAKP is committed to providing patients with tools and strategies to impact care no matter where you live, so this is a very exciting topic for us. Today, you will hear from a number of esteemed speakers, both dedicated to defining what true patient-centered decision-making really is and how these tools will help patients and clinicians support shared decision-making strategies that start and end with the patient. AAKP, over the past decade, has defined shared decision-making quite differently than many other kidney stakeholders here in the U.S. and across the globe. We believe kidney patients are intelligent consumers of health care and have the same fundamental human aspirations as any other person. This means that they share the same desires to pursue an education, work meaningfully full-time or part-time in a job or career of their choosing, and also have the shared interest in having a family, owning a home, and retiring securely. This is part of the reason why AAKP defines kidney disease as both a healthcare and workforce issue. But in order to achieve their aspirations, patients must have care choices and timely access to treatments that fully align and support their interests. These include home dialysis and transplantation, including preemptive transplantation. Deciding on which kidney replacement therapy aligns with the aspirations of a patient requires consultations with a qualified doctor who is fully capable and willing to think of patients as an equal partner in the process and who has a thorough understanding of how each therapy works. This is why AAKP is working closely here in the United States with the American Board of Internal Medicine to raise the knowledge and experience standards of certification for kidney doctors to include a greater understanding of home dialysis therapies. Doctors have an ethical obligation to fully inform patients of the clinical benefits and risks of one treatment option versus another, and they must understand that patients do not view these decisions simply through the narrow lens of medicine alone. Instead, these decisions impact the entire person's life. So naturally, patients talk to non-medical experts about which treatments to choose, including family members and loved ones, friends, and fellow kidney patients. And AAKP has identified an often overlooked concern of patients here in the U.S. and around the world that most shared decision-making guides miss. That is the importance of the role of faith, spiritual leaders and beliefs, and cultural values patients have when they are deciding the best and most holistic treatment that works for them. This brings me to welcoming our first speaker, Mr. Chris Kelly. Chris is founder and CEO of Engage to Activate. He is an experienced health literacy writer whose company has developed tools that provide health engagement among patients that promote critical thinking and lead to improved health outcomes through active learning, design, and behavioral changes. AAKP is honored to work closely with Chris in the development of AAKP's new Patient-Centric shared decision-making tool and has invited him to this year's Global Summit to share a sneak peek of this exciting and interactive tool that is on the horizon. Please turn your attention to the monitors, and Chris, I turn things over to you.
Thanks so much, Diana. It's great to meet everyone today, and very excited to share great information about a new shared decision-making tool that I'm working with along with AAKP. We could progress, if you can go to the next slide, I can walk through our project objectives. The first objective is to make sure that kidney disease patients have the most impactful consumer choice shared decision-making tool, and that this tool supports the most informed, effective, and holistic treatment discussions between patients, caregivers, and their healthcare providers. On the next slide. All of our excitement is really driven by 5 core attributes that make this tool very different, the first of its kind. Number 1, it's aspirational. Pulling through psychosocial hopes, dreams, life goals, and aspirations, many of which Diana just walked through. It is real world, developed with patients, for patients, versus by clinicians or researchers without a patient voice. It is accessible. It is unique, and I'll touch in a minute around our landscape analysis and some of the gaps that we're filling. And then it's global, translated and tailored across to reach all languages and countries. And I'll walk briefly through some deeper details around each of these core attributes. So we'll start with the aspirational, and you can move to the next slide. One of the models that we apply as health educators to ensure needs are met beyond medical and clinical is the biopsychosocial assessment model. This model obviously looks at medicine and the impact of kidney disease, but it goes farther to capture those aspirational domains that Diana just mentioned: family, fatigue, work. So we're making sure that we're leaving no stone unturned to manage psychosocial challenges around this decision aid. And the next slide. In addition, we're taking a look at the impact of weather disasters. There's a significant relevance to this given the increased awareness of home dialysis during COVID and the pandemic. Weather emergencies are typically missing from shared decision-making tools, and they should be a primary domain. And this has been supported by published research and across a significant scale. And on the next slide. The other key area is that we tend to think about patient support as coming from providers or support groups, but in many cases, recent research is calling out the impact of family, faith leaders, and other what I'll call healthcare extenders that support decisions and care for patients. It's real world, as I mentioned earlier, developed with patients, for patients. And then on the next slide, you can see a great screenshot from our first of what will be a series of 4 focus groups, literally working with patients, rolling up our sleeves, coming up with domains, format, structure, from soup to nuts. And we have 3 additional focus groups, and then there'll be a larger quantitative survey to ensure that we are getting that patient and consumer voice. Next slide. This is just a sample of some of the amazing quotes and stories that we heard, just elevating this idea that many patients don't realize that they are part of the team, that asking questions is not non-compliance, and that they basically are in a place to drive their care, and our shared decision-making tool will help them do that. Next slide. Next is accessible. So we want to make sure that this tool can be read and observed and heard, and that all patients can benefit from it. And to do that, we're going to leverage best practice design guidelines. And I'll walk through each of these really quickly. We'll start with WCAG guidelines, which ensures that any patient with visual or hearing impairment is able to access and benefit from the tool. Next, we have the IPDAS standards. IPDAS has developed a checklist, an instrument, minimum standards, and a checklist for publishing so that the roadmap is laid out in terms of process and function of the tool. And next slide. We highly value health literacy for print and usability for the digital channel used for the shared decision-making tool, again, driving clarity and activation. Next slide. In addition, often not discussed is health numeracy. Think about the data that patients have to process around treatment risks and benefits, the frequency of things like adverse events, and the probability of disease or disease progression. All of those are really important. So we will align with all the health numeracy guidelines to ensure that data and numbers are understood. Next slide. From an instructional design standpoint, and we talked a lot about this with our focus group members, we really want to make sure that this is offered across multiple modalities to accommodate many different learning styles: print, web, mobile, a call center, peer-to-peer, and then also incorporating motivational interviewing principles. And from the standpoint of emotional interviewing, I like to say decisions don't happen in one moment. Decisions evolve over time as patients work through their treatment and work through their different symptoms. So the motivational interviewing will help to make this tool fluid and help them to evolve and follow patients throughout their disease progress. And next slide. Unique. So we conducted, on the next slide, you'll see we conducted a landscape analysis, very robust. And the point of this was to really identify those domains that haven't been covered in prior shared decision-making tools. If you progress to the next slide. So this was review of 20 peer-reviewed articles, international guidelines and standards, MI guidelines. We looked at many different best practice SDMTs, and also made sure that we were looking at global guidelines from, for example, the World Health Organization for REACH. And next slide. Global. So, we want to make sure that all of our communications through the decision aid are translated and tailored to reach across languages and countries. On the next slide. As part of that, we really want to leverage and be part of the World Health Organization's people power, really to activate this intention to action and ensure that patients have the tools to understand their disease, understand their decisions globally, and have the best treatment outcomes possible. And then finally, once our tool is developed, we will work with AAKP to pursue SDMT certification and also publish outcomes so that others can learn from this tool, benefit from it, and we can continue to build in the research of shared decision-making tools. And then in terms of next steps, and you can click to the next slide, we will have a large quantitative survey. Once we're completed 3 more focus groups with patients, we'll have a final decision tool reviewed by AAKP and our patient focus group. We'll move to QA testing. We'll have a small pilot, and then we will be very excited to launch the consumer choice shared decision-making tool. And the next slide. And just want to thank Diana, AAKP, George Washington University for the opportunity to be part of this project and present today.
Thank you, Chris. Excellent presentation. We at AAKP are very excited and very much looking forward to the launch of the tool later this year. I would now like to welcome our next speaker, Dr. Peter Rutherford, Vice President and Global Medical Lead of Renal Care at Baxter International.
Thanks very much, Diana, and it's a delight to be presenting today at the AAKP event. And again, a huge congratulations to you all for such a fantastic, inclusive program, which has really exploring lots of things of benefit to patients in the US, but actually people all around the world who are the journey of living with chronic kidney disease. So I'm going to follow Chris with thinking, I guess, the other side of that equation, and that's what are the doctors doing, and how can the nephrologists really engage more effectively, more consistently with their patients. So I'm really going to present a little bit about what Baxter's doing and thinking about, are we having the right conversation? Next slide, please. You don't need me to tell you that CKD is very common, and that globally, what we know is that 850 million people have CKD. I mean, that's an estimate. There are clearly many, many more undiagnosed, and many, many more at risk. There are less people on dialysis, maybe 4 million globally. The challenge, I guess, is that only 12% are performing dialysis in the comfort of their own home, with a lifestyle choice that maybe suits what they want to do, work, being with their family, being at church, being wherever they want to be. They don't get a chance to choose that option which gives them that schedule that fits into their life, rather than having to change their schedule to fit into dialysis's life. And when you think about it, the clinical evidence would show that the vast majority of people, for instance, don't have any clear clinical reason to not perform peritoneal dialysis. And in fact, I was taught if you've got a peritoneum and a home, then you can do peritoneal dialysis. And if you can fasten a button, that's the technique that you need to use. So yet we've got this disconnect of most people that have peritoneal dialysis and only a minority do. And then just the next press, please. Yet this is a result of a very recently published survey from the UK, where they asked a large number of doctors and nurses, imagine if you were 40 and had the need to make the choice of CKD, of a dialysis modality, what would you choose? And then they repeated the question, imagining they were 70. 90%, 90% of healthcare professionals who were asked that question would choose home dialysis for themselves. There's a problem here, isn't there? There's a problem with what I say and what I do in practice. Let's explore that a little bit further. Next slide, please. Because if we move away from the numbers and come more to the experience, well, look at some of these quotes about the day that I learned what I was having to do, it just changed everything. My life was turned upside down by what was happening. Or the patient who is on 3 years on an in-center dialysis, but really that clearly wasn't the option that they felt was best for them. And when they were given the chance to choose, they could choose PD and could get back to the way they wanted to manage their own life. And Chris mentioned something very important about this, I think he called it the extender group, the people around the patient. Well, here's a child with their mother, and clearly that's an obvious example. But many of us have people that are close to us and want to advise us, and we want to take their advice. And I think it's very important, as we would never talk about a child without talking with their parents. Well, why is that different for anybody? And understanding them as a full person. And here's the mother who is able to help choose the therapy for her son, which give him a much more normal childhood. Next slide, please. And then if we think about, well, what's the pathway to that selection of different modalities? Well, it starts on the left-hand side with this understanding of the decision is based upon the clinical circumstance, and it has to be. There's a clinical circumstance, a set of clinical factors which need to be considered. But alongside those clinical factors are the values, the wishes, the desires, the goals, the things that matter to all of us, actually, about what we want to do with our own lives. And that's really important that that's considered equally alongside the clinical issues. Access to innovation is clearly very important and can modulate this choice. If I feel supported at home by remote monitoring, I'm going to change my view of life perhaps and my choices. So different innovations give me additional choices. And then I think this is something that I've realized a great deal this year in different parts of the world. There's a payment issue for the patient, which may be hugely challenging and really affect the choice. And we have to work together to reduce the impact of that and actually remove that from that discussion. Education in the middle, clearly very important. Seeing is believing, seeing the dialysis, understanding what the different modalities will be, for me, is clearly very important. And that begs the question, though, did it really happen? Was it delivered effectively? What was the mode of education? Did I get an educator who understood how to educate me, or just educated them like school teachers when I was a boy who educated as they wanted, rather than thinking perhaps what we needed? And then at the end of the concept is the critical part, which many of us would just see patient-doctor interaction, is the shared decision-making when together there's a reaching of the decision. But it's not if we had the conversation, like a tick box on a consent form, is how has that conversation gone? How has it been for the person that really matters, and that's the patient, because ultimately the decision is going to lead them to life-changing changes in the way that they live. So it's this conversation and about the how, not if to do it, not is it a good thing to do shared decision making, but how is it done? That is something that AAKP is working on, and that we're delighted to collaborate and work together on many aspects of this. Next slide, please. So what we're doing is in our education for physicians, online or other electronic formats, or whichever format we use, is to give physicians a framework, and nurses, to give healthcare professionals a framework to think through. How can I evaluate the options clinically? How can I use my knowledge and experience of dialysis and my knowledge and experience of disease states, but then critically listen? And actually, before listen, I've got to elicit, I've got to help the patient to express their values and preferences. And that conversation will be undoubtedly not just with the patient, but will be with those that matter to them, that they are the ones who decide who those are, and can give the input and the support that the patient will need. And the framework that we're looking at and using is a very well known one for healthcare professionals, and really it's agnostic to the disease area. And I mean, when you read this, it's so logical, so simple, so obvious. Number one, it's all about share. Seek your patient's participation. And seek doesn't mean just try once and then give up. Many of us disengage with things, but with help we can engage again. So really actively seek. Then help your patient explore and compare for them the different options. Then assess, and this is the key step. Assess your patient's values and preferences. Reach a decision with the patient, not separately, with the patient. And then evaluate with the patient, and evaluate afterwards. Has this been the right decision? Do we need to change our approach? Do we need to revisit this decision? Evaluate and then put into practice the next steps to reach that decision. So this is the framework that we're using in our online education for HCPs. Next slide, please. And this is the final slide, which is very much focused on the how, and the words that we use, and the approach that we use. It's based upon and is using vignettes of cases, experiences of challenges, and how to get through them. The aim is to help improve clinical practice. It does deliver academic knowledge, but really its prime objective is to improve clinical practice and improve practice of delivery of care for people with CKD, and improve engagement and satisfaction through a very thoughtful two-way dialogue. And on the right-hand side really are some of the key elements of the do's and don't things around shared decision-making that we're pulling out in our online education. At the top, needing to increase participation of the patient, yes, and those around them, but also of the team. Nephrology is a multidisciplinary sport. It's an activity which nurses, social workers, psychologists, dietitians, and doctors, we all participate. We all need to engage together to help the patient and those near them to make that decision with us. Bottom left, clear explanations. I'm a doctor. It's easy for me to use technical terminology, but really understanding the right language to use for the right person and in the right language, because many of our patients, I'm from the UK, many patients, English is not their first language. And it's no good me participating in one and they're participating in a different one. So understanding and explaining clearly, seeing it, believing it. Right-hand side on the bottom, and Chris mentioned this, and it's really important, communicating risk. In numerical terms, you know, it's not, this is risky, you've got a high risk. That doesn't mean anything. So it's giving the risk and choosing the words very carefully as well. Just listen to this one. The chance of getting peritonitis is once every 2 years. The risk of getting peritonitis is once every 2 years. As a native English speaker, transferring chance and risk and changing my voice imparts a different understanding of risk. How we say it and what we say clearly and giving a balanced view. Risk of peritonitis, risk of sepsis with a central venous catheter. These are the kind of things that we're trying to do in this online education. The one in the middle is not chosen to be in the middle by accident, because we come back to our first statistic. 90% of doctors and nurses say they would choose a home dialysis, and yet they only facilitate 12% to have home dialysis. There's a problem, isn't there? And I think for me, avoiding bias, and deliberately there's no unconscious in here, because unless we are unconscious, every bias is conscious. So if I am biased about a patient because of their ethnic origin, their age, their gender, their educational attainment, whatever it is, I've got to be aware of that chance. I've got to recognize that's possible because we see it. And I've got to actively manage what I do to avoid bias, because all patients should have an equal chance to choose and an equal chance to understand. I'm going to finish there. Thanks very much, and it's been a pleasure to participate and to work together on this, helping patients and doctors work together to make good decisions.
Thank you, Dr. Rutherford. AAKP will be honored to work alongside you in the development of this physician-based tool to support more substantive dialogues between patients and the doctors they choose to care for them. Thank you. I'd now like to turn our attention back into the room to welcome a close ally and good friend of AAKP's, Ms. Michelle Seger. Michelle is a Vice President of Venn Strategies, which has established the International Home Dialysis Roundtable to address strategies to increase home dialysis utilization across the globe. AAKP has been a very active member of this international roundtable, and their work is highly valuable. We are pleased to have Michelle with us to discuss the 4 pillars of the International Home Dialysis Roundtable, as well as their new International Home Dialysis Resource Center. Michelle, I invite you to the podium to present.
Thank you so much, Diana, and thank you to AAKP for having me here today. I'm super excited to talk about the International Home Dialysis Roundtable. This was something that was born out of the pandemic, where we realized that stakeholders across the world really needed a place to go to talk about the impact of COVID-19 on kidney care, especially on home dialysis. And to our surprise, this has actually continued since 2020 into today and hopefully into tomorrow, because it's something that was very needed in the kidney disease community. So I don't know how to work this clicker, so I'm just going to say next slide, please. So who are we? We are patients, clinicians, and other advocates from across the globe. We have every region that you can imagine represented, and we have raised everyone's profile to be on equal playing field. Patients and clinicians can have conversations with each other. They sit on the same panels. They write the same papers. Everything is done in a team and collaborative effort. If you look on the right side of the slide, you can see a list of all of the organizations that have served at least one term on our steering committee, and you're going to see a lot of diversity there. In the type of organizations, in the geography, in what they cover, in everything. So really bringing all of those perspectives together is what we did. And we didn't know it at the time, but this is actually very relevant to shared decision making, as Chris and Peter talked about, ensuring that those relationships between clinician and patient are strong enough to have those conversations about what the right treatment modality is and making sure that those options include home. So next slide. So what do we stand for? You'll see here there's 4 pillars on the screen. These were developed in our first 2 roundtables that we held in 2020, and we actually ended up publishing a paper that established a commitment by not only the steering committee, but everyone that was in attendance at that year's event to work in tandem in our own organizations at home and then also together on those 4 pillars. So we'll talk briefly. We'll go to the first pillar on the next slide. Can I get the next slide? Thank you. So the first one is international standards and cooperation. And before I even get into what that means, I want to note that the bolded portions of each of these slides are really where our patient perspective comes into play. It is so important that we have woven patient perspective into each of the pillars. So international standards and cooperation, what is that? That is an overview for where can everyone who came to the roundtables agree? What can we do together where everyone says this is the outcome that we want? So the most obvious and elementary, really foundational piece here is we want to increase access to home dialysis. So that's where we started. Next slide. The next one is patient empowerment and education. Not only did we weave patient voices into every pillar, but patient empowerment actually got its own pillar too, because we think it's that important. So what have we done here? We have worked on ensuring that patients are an integral part of every single piece of programming that we do. So later you'll see a slide that lists a lot of our activities, and for this one I just want to talk about a couple. We have had multiple webinars where we've ensured that patients and clinicians are sitting there right next to each other talking about the important topics at hand. We have also ensured that in our publications we have patient authors who can provide their own perspectives in these peer-reviewed journals. And then finally, in our events as well as in events that we participate in, we make sure that it's not simply one person with one background talking, but we represent everybody. Next slide. A culture of support for home dialysis. This pillar is directed more at the clinical community and efforts that we need to go from status quo in many countries, which is in-center dialysis, to a culture that really supports and accepts home dialysis, and it isn't a fight to get access to home dialysis. So here we're talking about clinical training, like Peter talked through, making sure that we have education for clinicians available on home dialysis in multiple languages, and that's relevant not only to the developed world, but also to developing countries who also participate in our roundtable. Next slide. And finally, the fourth pillar, mitigating institutional and government roadblocks. Here is where we're going to talk about policy advocacy and lobbying efforts. And we have really exciting work that we've done here in the US. We have talked with the Centers for Medicare and Medicaid Services about how to increase access to PD catheter procedures during both a pandemic or emergency state and during so-called regular times. And we've also published a paper on that same topic that is applicable worldwide. So that's just a few examples of what the pillars mean and activities that have taken place underneath them. Next slide. This is a list here that you can read through of just things that we have done, but what I want to actually point us to is the two pictures on here. These are the two articles that we have published. One was in Kidney Medicine and one was in the Clinical Kidney Journal. We are really passionate about making sure that what we are doing at the Roundtable, the information that we're taking from a clinical and patient background, gets published in a place that it can be read and utilized by the broader community. So we're very excited about those publications and hope that we can continue doing them in the future. Next slide. And then the probably most exciting thing that I have to talk about is last. This is the International Home Dialysis Resource Center homepage. This is a website that we created after our first Roundtable way back in 2020. Some of the first feedback that I got was, okay, but are you going to put this information anywhere for us to be able to access afterwards? We don't want to lose all of the conversations that were had at these roundtables, and we want to make sure that we can continue to reference them, that people from outside who didn't attend these events can know what's going on. And so it took us a little bit of time, but we are finally launching that. We launched May 1st, and we're excited to say that we have over 100 pieces of material on this website. They have all been vetted by the steering committee, and it is a really broad range of resources for people, and it includes everything that we've done as a community, but also things that individual members have said, this is important, this will help advance home dialysis. And so I want to take a minute to plug here that if you have any resources that you feel like should be included on this resource center, please let us know. Diana, I think, would be willing to give my information out, and I would absolutely love to hear from you. We want to make this as usable for everyone as possible. So I think that is my last slide. Thank you again for the opportunity to speak today. I really appreciate it.
Thank you, Michelle. As always, it's wonderful to have you as part of our events and to share the excellent work of the International Home Dialysis Roundtable. I'd now like to switch gears and invite some experts on shared decision-making based on their real-world experience. Joining us from India is AAKP International Ambassador Vasundhara Raghavan. Vasundhara, pardon me, is a dedicated AAKP International Ambassador, founder and CEO of the Kidney Warriors Foundation in India, a published author, as well as a caregiver to her son who has kidney disease. Please turn your attention to the monitors for her remarks.
Thank you, Diane, and American Association of Kidney Patients. It's a good opportunity for me to come and talk about the shared patient decision-making. The aim of this tool is to prepare each patient to be involved in the chosen treatment and to empower each patient to be mindful of the treatment and manage it well. The important thing is that once a person has been detected with chronic kidney disease, there's a lot of confusion and people are wondering what to do next. But when you have chosen a treatment, either it can be a dialysis or a transplant, one needs to be very dedicated on the path of the treatment in order to stay healthy with chronic kidney disease. Kidney disease is a huge lifestyle change. It has to do with learning to live healthy even with kidney disease. This tool will guide patients in these aspects. It will give you clear indication on the treatment goals, the clinical part of it, It'll give the professional or the employment goals. It tells you exactly what you should do if you are employed or you're under some education. It will show you your lifestyle goals, what you should be doing to have a good, healthy lifestyle, and the personal goals with which you can manage your treatment well. Every patient will have this goal, the goal to receive good treatment. But this goal will come with a lot of work involved. It will mean that you need to meet a nephrologist who can guide you. And if you are not comfortable with the nephrologist, you must try to change even at an early date so that you don't confuse yourself. The next thing is to find a nephrologist who's close to you, located close to you, because chronic kidney disease will have a lot of comorbidities and many challenges that you may face. So when you are taking a nephrologist who's far away, in an emergency, it may be difficult to travel. The most important of all this is to understand chronic kidney disease. Chronic kidney disease is a challenge for everyone because one needs to know that it's not only about the kidney that is affected, but once the kidney is affected, many parts, many organs could be affected. So to understand kidney disease, you have to know what the kidney does, how it purifies the blood, and how your kidney also has to manage everything that you consume, right amount of protein. It needs the right amount of phosphorus. Excess of potassium or phosphorus or sodium can create an imbalance. Managing the blood pressure, managing blood sugar if you're diabetic, all this is important. And to understand this is the greatest challenge. But learning this early will help you manage your disease much better. After we have understood the disease, it is important to accept the disease. It is like some verdict that has been given. Yes, your kidney has failed. So once this is informed to you, the patient has to learn to accept instead of going around in a confused state trying to look for treatments, because the time you lose in looking for the alternate treatment is the time you should use to understand what is chronic kidney disease and why you need to manage it properly. Once you have chosen a treatment, whether it's dialysis or transplant, one needs to dedicate time to follow the treatment so that you can understand what are the implications of this. What does a transplant mean? Transplant is the gold standard. Everyone should aim to get a transplant. The kidney transplant gives you a long life. You can live normally and you can enjoy a good quality life. But there are some people who can't get a transplant because there is a problem to get a donor, or there may be an inherent kidney issue which does not allow you to get a transplant. So if you are going for dialysis, one needs to understand that dialysis also has three options. One is the hemodialysis at the center, one is the peritoneal dialysis, one is the home dialysis, which you can conveniently do at home, which is called the nocturnal dialysis. So being dedicated to your treatment is very important, and not getting confused or diverted because someone else has told you that this is how you can reduce your creatinine. Someone has said that herbal remedies are better for kidney disease. So these type of theories that come out, they are not clinically verified, and there is no research to prove that this is authentic. So it is always good to follow your nephrologist, follow a guide of a line of treatment so that you don't get confused. A professional goal is very important to be productive. If you are already with a job, a nice, good job, it is important to maintain your health very well so that you can continue to be productive. Being productive is important for many things. Firstly, how will you be productive? You will need to adjust your timing, your treatment timing. If you need to go to a doctor for an appointment or for a blood test, you need to factor that time and inform your office accordingly. You need to be open with your employer, discuss the issues on hand, and show him the positivity of your health. Not that you are concerned with your health, not that you're worried about your survival, but that you want to be on top of your health and take the kidney disease along with you. Work always keeps mind busy, and cash is needed for healthcare. So being employed, or if you have some education, trying to keep your education going is the most important thing, because this gives you a purpose in life. The goal for a good lifestyle. It is okay if one person has a kidney disease. There are many people who had a kidney disease and try to live a good life by modifying their lifestyle. What does it mean to modify diet to manage renal health? The kidney cannot process heavy protein, lots of phosphorus in diet, potassium rich food, sodium rich food. So one is advised by the doctor at the very early stage to modify the diet to manage renal health. So low sodium diet, less of phosphorus, no soft drinks, no chocolates. That will help you to manage your phosphorus levels better. Then there is something like a phosphate binder. Talk to your nephrologist about that. And have low potassium food. Avoid the potatoes and the bananas. When we say be mindful about what you may avoid, it means that you can avoid a few things, but not avoid protein. You need a good protein, but the portion size has to be less. So everything has to be taken in the right proportion, not over consumption, and not too less a consumption that you become malnourished. Make exercise a part of your life, because that will keep the body and the parts of the body active. Walking is the best exercise for CKD and for dialysis also. Dialysis patients doing an exercise will keep their blood circulation good, and during dialysis they'll have face less problems on cramps and other problems. Giving up smoking is one aspect that can be tough, but it's always good to get rid of that habit, because it can create a lot of problems and comorbidities as the disease progresses. Alcohol consumption can always be as per doctor's advice. Being active on social media, discussing your problems with your friends or people in the same journey will also help you to keep your mind occupied. The personal goals that one must have is, yes, I want to accept this disease and see that I can live long. I want to do all that will keep me healthy, even if it means I have to modify my diet. Decide to live long with the right choices. If you make the right choice, there is a chance you live for 50 years post transplant, for 50 years or more on dialysis. And if you are diverted and try other alternate therapies, you may lose those wonderful years when you could be living healthy with kidney disease. Mind and body needs to be aligned with exercise, prayer, and meditation. Because once we do some exercise, we are kept physically active. Our mind is occupied on reaching the next goal. If I have a goal of 5 miles today and 10 miles of walking next week, and if I start putting that target into practice, my body be will get accustomed to good exercise habits, and my mind will be very relaxed. I will be able to concentrate on what I should do, and I will always plan the right things for my healthcare. If you are having a good communication with your doctor, with your dietitian, and you share all your experiences with them, you'll be able to manage your health much better. Life is a gift. One needs to keep faith, purpose, and be empowered by knowledge. The tool that AAKP will provide will empower you with knowledge. It is always better to ride on the horse and not be pulled by it. This is Vasundhara Raghavan from Kidney Warriors Foundation, India. Thank you very much for giving me this wonderful opportunity to address this to the community at large. Thank you.
Thank you, Vasundhara. As a caregiver, your insights and lived experiences are invaluable, and we appreciate your support in the development of our upcoming shared decision-making tool. I would now like to end our session by introducing our final speaker, Mrs. Jennifer Jones, AAKP Vice President, Ambassador, and retired United States Marine Corps veteran. As a former dialysis patient with experience in in-center and home dialysis and a 2-time transplant recipient, Jennifer knows what patients need most: true patient-informed shared decision-making strategies so they can choose the right treatment at the right time to support their aspirations. Jennifer, I welcome you up.
Thank you, Diana, and thank you, patient leaders, caregivers, family members, elected officials, healthcare providers, researchers, engineers, industry leaders. I think I got everybody here, and those tuning in virtually today. I am truly honored to be here to discuss a topic that is close to my heart, well, actually to my kidneys really, patient-centered shared decision-making. When I received my diagnosis in 2011, one of the first thoughts that I had was, I don't have control over my life anymore. I could no longer serve in the Marine Corps. Despite living a healthy lifestyle, I'm now told that I have to take 13 different medications. I was at stage 3, so I didn't begin dialysis right away, but I was dealing with severe fatigue and edema, which not only affected how I looked at myself, but how my peers looked at me as well. All because of a disease that no one knows the cause of. That didn't sit well with me because ever since I was a child, I always wanted to know why things are the way they are. Yeah, I was the kid who asked why after every answer that was given. So for all the parents who have children like that, I commend you. Looking back, I appreciated my mom's patience with me. I also appreciate that as a nurse with around 36 years of experience, she stressed to me how important it was to learn about my diagnosis, to be an active participant in my treatment and care, and to never stop asking questions. Every one of us who has this illness deserves to be an active participant in our healthcare decisions. Our voices matter, and our choices should be respected. True patient-centered shared decision-making is a collaborative process that values the unique perspective of each patient. It recognizes that we are experts in our own lives and experiences, and our healthcare providers should treat us as equal partners in decision-making. First, I have to acknowledge my privilege. I can say that I am so grateful for my nephrology teams at Walter Reed National Military Medical Center in Bethesda, Maryland, and Hunter Holmes McGuire VA in Richmond, Virginia, because I truly felt centered and a partner in my care every step of the way. If it wasn't for that, I don't know if I would be standing in front of you all today. For me, I felt that the shared decision-making tools provided by my nephrology teams were sufficient when it came to treatment modalities, the benefits, risks, expected outcomes, and impact on my quality of life. Please do not take this as a slight against them. However, there was no in-depth discussion on how this lifelong disease was going to affect the goals I wanted to accomplish, my career options, maintaining a social life, or my mental health. Before diagnosis, I lived a life that involved risk, experiences not for the faint of heart, and as much travel as possible. That was pretty much over. It was a shock to me. I was literally pulled out of a war zone in Afghanistan into this war zone that is chronic kidney disease. I was ready and willing to make the sacrifices to serve my country, but like many of my fellow patients, I was not prepared for what I would have to sacrifice to this illness. I realized on my own that I had to pretty much recreate how I want to live my life because of my limitations, and honestly, I'm still having challenges with that. As Chris discussed, our hopes and dreams are so important to us and must be acknowledged and included in a shared decision-making tool. Keeping an individual alive may be the goal for healthcare professionals, but what is life if we aren't able to live it on our terms? I'm excited about releasing our consumer choice CKD shared decision-making tool, because having a tool that is aspirational, real world, accessible, unique, and global empowers us to make informed choices that align with our personal values and goals. Because sadly, not all decision-making processes are patient-centered. Sometimes healthcare providers may unknowingly impose their own beliefs or biases upon us, neglecting our unique needs and desires. Another issue arises when information is withheld or oversimplified, limiting our understanding of the full range of options available. When we are not provided with all of the facts, it becomes challenging to make decisions that truly reflect our best interests. Prior to the summit, I hope that you all had the opportunity to watch the interview with Paul and Dr. Rodriguez on the origins of the AAKP GW Global Summit. It began in 2018 when Paul was invited to speak at the United Nations Convention on Aging, Ethics, and Disease. While on a panel with a number of leading health professionals, he was shocked by the discriminatory and disempowering perspectives shared about people living with non-communicable diseases. There is a disproportionate emphasis among some professionals to discuss end-of-life conservative care with older individuals instead of receiving a transplant when that is still a viable option. Let's consider the detrimental effects on these older individuals when they're pressured to choose conservative care through a distorted version of shared decision-making. When their autonomy and choices are disregarded, it can lead to reduced satisfaction with care, compromised mental and emotional well-being, and a sense of helplessness. It is a shame that there are those who would look at them as a burden that could no longer contribute to society. It's a shame that these individuals never consider that one day they may be faced with a provider attempting to convince them that because of their illness, conservative care is the best choice. As you can see, there are many who have received a transplant, or even while still on dialysis, work hard to be self-sufficient and are dedicated to advocate on behalf of kidney patients and serve their community in many ways for the rest of their lives. It is also important to recognize that pediatric patients have the right to be involved in decision-making processes concerning their own health care. They should not be deprived of the ability to have a say in matters that directly affect their own bodies and lives. Their voices should be valued and respected, and efforts should be made to involve them appropriately according to their age and developmental level. Pediatric patients, when given the opportunity, can contribute valuable insights and preferences that should be considered in their treatment planning. Exclusion from decision-making constrain the trust and communication between pediatric patients, their parents or guardians, and healthcare professionals. This is why it makes sense for individuals with firsthand experience with this disease to create a shared decision-making tool. By being directly involved, we bring unique insights and perspectives that only someone who has walked in our shoes can offer. Patient choice and autonomy lie at the heart of quality healthcare. Each of us deserves to have an active role in our own care decisions, regardless of our age or health condition. By recognizing that we are unique individuals with our own values and preferences, we can foster a patient-centered approach that respects our autonomy. When our choices are respected, it not only leads to higher satisfaction, but also improves treatment adherence and ultimately enhances our health outcomes. We must advocate for true patient-centered shared decision-making, challenging healthcare providers and systems that fall short here in America and across the globe. By involving kidney disease patients in creating shared decision-making tools, we amplify our collective wisdom and pave the way for a more patient-centered future. Thank you for your attention.
Thank you, Jennifer, and thank you to all of our presenters. I believe this session has done a superb job of outlining not only what shared decision-making is defined by patients, not only what shared decision-making is as defined by patients, but also what it is not. It is time that we adopt the true definition of shared decision-making, and I'm confident that the tools being developed by AAKP, Baxter, and the resources from the Home Dialysis Resource Center will support that paradigm shift.